So we'll have a brief discussion on the papers which were presented. Any specific questions from the audience is welcome. So we'll take one by one. And addition to this is the main organizer, Dr. Kumar Prabhash. There are two abstracts which actually need him, and hence he is pulled here. Thank you. So, as sir just said, there are two articles where they're on renal transplant patients where screening for renal cancer seemed to be important. So, we have been in cancer, and sir just made a comment that been seen some 2, 3, 4 patients over a long time. So, Dr. Kishore, what do you think are problems in screening in RT patients, renal transplant patients?
I think, no, the journal said that, has mentioned that it's not cost effective, but from an Indian perspective, I feel, no, we have almost like an outpatient ultrasound. Ultrasound tour with a radiologist does not cost much. So I think it's very much possible because it's very much available like in India in imaging modalities. Unlike in US where a CT scan costs $6,000 and a ultrasound costs $300. So it is really possible in India. I think I would recommend that. And pre-operatively, when we have seen, we screen for generally we do an ultrasound abdomen before transplant, and sometimes we end up doing a plain CT also, which can pick up some of the lesions. And most of the lesions I have encountered are low-grade RCCs so far. So we do a pre-transplant nephrectomy initially, and then wait for the pathology. If the grade is less, we go ahead with the transplant. That is the current protocol that we form. We don't wait for the 2 years.
So what you said is a current guideline in transplants?
Or there is a guideline also. There's a guideline also recently it has come up.
Ganesh, can I make a comment?
Yes, sir. Please.
Most of these events are later in the transplant recipient. 99% of the times this patient doesn't see a urologist. He's been followed up with a nephrologist. Nephrologists are not cancer oriented. They would be simply looking at renal functions and moderating or modulating their therapy. That's one of the main reasons.
Can I just
please
put in?
Yeah, you wanted a comment.
First of all, I have worked in a very high volume center, which is the Oxford Transplant Center, for very many years. And the incidence of that renal cancer in transplants, in my experience, has been very low. That also is applicable in India. If you analyze the data that is already published data, whatever RC happens in renal transplants happens mostly in the non-Asian populations, in the African population. Okay. So I'm a little skeptic about the significant incidence of RCs in transplants in India. But even if it happens, I don't think screening is going to be a problem. I don't think it is going to be actually cost effective. It is not going to be cost effective. It is actually going to be cost effective, but for the wrong reasons, we are going to do a transplant.
So, I have a comment. Recently, we have noticed...
Quick comment.
Especially in cases of cadaveric renal transplant, when the ultrasound is being done by some experienced person, there is a very high possibility of missing some suspected lesion, and later on, over a period of time, we will going to diagnose it as a RCC.
Yeah,
it has happened.
So this slide says the reasons actually.
So I think now we have changed our protocol, and now in all cadaveric renal transplant recipient patients, we are doing CT scan to avoid such things, and so that the possibility of having RCC in the later phase of the life.
How do you do a CT scan in cadavers?
No, I'm talking about recipient.
Okay, recipients. Okay. So these were just quick questions to get the thing straight. Dr. Mandani,
I think
how
I will
often?
make just quick comment on screening.
Yeah, please.
I mean, it's heartening to know that we are discussing this paper. I'm really delighted to know that this thing has happened. But if you look at the actual incidence of RCC in 2000, and they had a series of 2,000 patients in 20 years, 16 patients had RCC. So KDIGO guideline does not recommend routine screening. In EUA also says in high-risk patient. But for the first time, we Indians should recommend screening for recipient. It is not a big deal. Annual screening with ultrasound is not going to kill anybody. Just think of yourself as a recipient. Would you mind not having ultrasound every year.
Wait,
But
is
sir,
it,
as
is it
such-
recommended right now? No.
No, that's what I'm saying.
Okay.
This is the first time we should give recommendation.
So Puneet, you operate cancers. How often you get a reference? Have you operated one like this? I mean,
Very
I've
rarely,
been in
very rarely. I have
TMH
not,
where there is no renal transplant, so I have no experience.
Patients are dying with cancer.
Yeah.
But sir, but as such in India, every renal transplant patient is getting an average of 4 to 6 ultrasound every year
So
by
Saurabh,
the nephrologist.
Saurabh, you said you have been seeing transplant in recipients, right? No.
Yeah.
Have you seen renal cancers in transplant recipients?
No.
Till now, I have
Very
done
rare.
5. All of them have been low grade. I have never encountered a
All clear cell?
yeah. All
One
clear
patient-
cell are really like high grade lesions I have seen.
I just
These
want to
papers
have
had a mix of mostly clear cell, then few chromophobe, and then papillary.
mostly
Clear
clear
cell I
cell.
have seen. Almost all of them.
If you can, I just have one point to discuss here. For transplant patients, like, is there like we are talking about screening, is there a particular category of immunosuppression or drug which causes more patients more prone to cancer? Like TAC is supposed to be a cytotoxic, and in patients receiving tacrolimus, the incidence of cancers is more. Mostly these are skins or lymphomas or leukemia. So, but these cancers can also happen. So, is there a particular thing, like if patient is receiving tacrolimus, you should screen more for that?
I don't think it is drug based in the literature.
No,
Dr.
no, very
Kishore,
unlikely.
anything? I think the
Occasional
immune suppression
anecdotal-
itself is a big problem.
Anecdotal reports of TCC coming with cyclosporin, that is otherwise no, not much.
So again, coming back to one point raised by Jagdish Kulkarni sir.
Ganesh, can I make? So I think so now, whenever we have screening, the criteria for screening remains similar, and we need to keep putting, does it fit into it? Is it a significant problem? That's first. So that we need to say it. Second, that does it cause the kind of mortality what we're looking for? Third, do you have a test which can really pick up early to change the natural history of the disease? And then to show that if you did it, it did decrease at least the disease-related mortality. And that's why screening is a big problem. Which any disease you'll keep seeing, we know PSA story, we know breast cancer story. So be careful here. What I heard that it's not as common,
So
we talked
it's
about.
not common. So are we missing cases, as sir mentioned some time back? I mean, they are not living. I think transplant patients are living quite long now.
The premise of doing screening, no? Because
You're not screening
Yeah.
one.
8% is a significant screening, much higher than prostate
Yeah.
cancer in this
the
I
premise
think
of
let's skip this.
the premise of doing the screening, no, because they have acquired renal cystic disease, which is a precursor of malignancy. So people who are on long-term dialysis, they develop this cystic disease, which has a potential to progress to malignancy. So if you have a pre-op, multiple cysts in the kidney, then probably that person's
Should be screened.
worthwhile doing screening.
So we should have some policy, as Dr. Mandani said. The
Somehow we can have a
KDIGO
reason for anecdotes. For that anecdote shouldn't become the routine part of your.
Dr. Kumar, what you are
Yes,
saying is screening is for general population. Here we are not talking of general population. Here we are talking of the
Transplant
recipients
population.
who are already have got a disease in their body, for which they are going for regular checkup by their blood, serum creatinine and all that. In that setup, once a year ultrasound is not a big deal.
Sir, I got your point. And when I was saying that, I meant for this. The criteria that it is, if in your
So this is the
kidney
smaller
transplant,
population.
if your kidney transplant patient, if this incidence is too low, criteria remains the same. The test should be decreasing, it should be picking up early. You should be able to treat to decrease the mortality. No, those criteria, wherever you do, remains the same. You need to fit those criteria. I do agree. It's not a population-based screening I'm talking about.
Okay,
But if you-
I think we'll.
But if you have
Ganesh, one last-
they have more potential to develop other malignancies in the abdomen.
Go on,
So
go on.
It might be worthwhile to get an ultrasound for kidney transplant recipient.
Got it. This is eminence-based guideline. We say it, and I also do it, and that's
Yes,
fine.
Santosh, anything?
Just the recipient kidney which is already affected by CKDs generally don't get clear cell or chromophobe RCCs. There is a category of RCCs called as ACD, cystic disease associated. It's a dialysis associated cystic disease which occurs and then develops. That's got a specific morphology which is completely separate and
these-
different from conventional.
These papers had the RCCs.
That's a strange, funny. I did not reach that.
I
time,
agree, but these papers had clear
and the
cell
recipient,
chromophobe and
the
papillary.
donor kidney generally has PTLDs, which are called as post-transplant lymphoproliferators. That's the commonest thing
Maybe.
of lymphomas, because they immunosuppressed lymphomas are the common malignancies.
And I agree. And for that, there can be some argument about it that do you want to have a screening for post-transplant lymphoproliferative disorder? That because that's the commonest disease, the commonest malignancy you have in that setting.
But that acquired cystic disease RCC.
I think we'll go on to the next abstract. Saurabh, sorry. Development and validation of a nomogram predicting intraoperative adverse events during robotic-assisted partial nephrectomies. So we have a lot of surgeons here. So we do have predictive models, Puneet. And a lot of things you consider when you are going to tell a patient about partial robotic, partial open, partial whatever. So how do you take it?
I typically, after the CT scan, we do a renal nephrometry, what we do right now, and especially for the, truly speaking, in clinical practice, if it's a very simple, straightforward, laterally based mass, I don't do anything for that. For a complex mass, which
I guess, but that simple mass also, at least the renal nephrometry,
yeah, nephrometry
we do.
is done, and more so in the terms of size and
Right.
if it's an endophytic component. Because for every partial nephrectomy, what I do, I always use an ultrasound.
Okay.
So, but if it is a complex mass, right now what we have is a renal nephrometry score, what we most commonly do. We take a consent with the patient.
Right.
Now there are few softwares in which you can do a 3D modeling and you can predict the how difficult it is going to be.
So coming to that last question, does imaging recon and 3D printing also similarly help you as we concluded in this article?
So I am not doing it right now. So the 3D printing, yeah.
Okay, so coming to, sir, I have a question for you. That next question, extra variables were put in this nomogram. So do you think they cover up all the gaps?
No, it doesn't. I mean, you see, the main issue, the theme of your nomogram should be your ischemia time. If it is complex, it takes more time. The ischemia relates also to your AKI and the duration of the AKI, which is also mentioned in the paper that was discussed. So all our philosophy regarding nomograms or counseling should actually revolve around what is your assessment about your ischemia time that is going to happen.
Sir, but don't you feel now enough discussions have happened on ischemia time? Ischemia time probably now is mattering when the parenchyma is as such in a not so normal state, or the recovery, the left out parenchyma after cutting the tumor is very less, or the left out parenchyma has got a problem. So ischemia time is also technically important in patients who have solitary kidney or a deceased or a semi-deceased kidney.
Yes, that is why the function is important. You see, it is not only the imaging and the radiography so far that we considered, it is important the duration of, the proof of pudding is in eating. Your ischemia time may be not 25 minutes, 20 minutes, 30 minutes, but what is the effect of that ischemia time as far as the recovery duration is concerned is very important.
1 minute before you. I mean, honestly, I have done a partial for 1 hour and patient is absolutely fine.
Because his recovery, what was his kidney injury?
It was less.
Yeah.
But so, I mean, we just keep on shouting about ischemia time, ischemia time. It's not, I was saying, not always important.
Yeah, in these situations, transient rise in the creatinine may happen, but usually they comes to the normal.
So that transient is also an AKI which comes back to normal with good recovery and healing.
Yes, one thing.
Probably.
Second,
Those who do not come back is what matters.
Right. So recovery of the left out renal parenchyma post ischemia. Kishore, what is your comment on that? You do a lot of partials.
I think, again, nephrometry score may not really correlate with the complexity of the surgery, because even at hilar tumor, sometimes we can do an unclamped partial nephrectomy. That is quite easy to do with the hilar tumor. On the contrary, a cortical tumor, it's very difficult to do an unclamped partial nephrectomy. So it does not necessarily correlate with the complexity of surgery always. Of course, there might be some degree of correlation. So, and there are a lot of other factors. Say, a 3 centimeter tumor in an obese patient and non-obese patient, it might differ a lot. Toxic fat, presence of toxic fat, the location and the number of arteries. These all like increase the complexity, and untoward incidents can happen. Say, if you damage an upper pole artery, which is more likely to do that. So, I think it's very difficult to have a
continuation to the Dr. Kishore's point, like obese patient, tumor in the previous operated kidney, and the obese patient, solitary functioning kidney, sometimes ectopic kidney, horseshoe-shaped kidney.
Why obese patient particularly? Because obesity otherwise should not cause anything.
No.
There is no literature data support on that.
Just my question is, like suppose we are operating on the obese patient.
On evidence basis, I don't think obesity stands anywhere.
Technically, sir, in obese patients doing surgery, a lot of fat.
If you're doing robotic surgery.
In the
easier on the obesity
easy maybe,
side.
but yeah, it's not about only robot. Surgery per se in the obese patient vis-a-vis in the lean thin patient is easy. And
I think come to your specific point.
Yeah. So other factors also play important role other than the tumor specific factors.
Oh, that we discussed. Gopal, anything you want to say specifically?
Sir, regarding...
There are a lot of nomograms.
Yeah,
I think after yours also more will evolve.
Yes, sir. Definitely. So this is different from others because in this we have looked for intraoperative complications, and most of the models previously, like renal nephrometry score or PADO score, they were mostly based on post-operative complication or post-operative outcomes.
Right.
First. Second, and as sir has pointed out regarding the ischemia time, we had taken ischemia time into consideration, and it was not found to be significant on univariate analysis. And also we had taken BMI. It was not found to be significant. So we had taken 18 preoperative parameters, which almost covers every variable. So out of those, only 5 were found to be significant. And there can be a never-ending ongoing debate on ischemia time. So
no, so you did validate the score, right?
Yes, sir.
So in your experience of internally validating this score, what change happened?
So regarding
in your practice of NSS?
So this model
means obviously you could predict probably more better the intra-op adverse events.
Yes, sir.
So what did you change in practice?
So sir, for practice to change, I personally believe nomograms are difficult to use. So right now
then
we
they
are
should not be made.
Yeah. So right now we are in process of developing an online web-based application, which can develop us.
But that web-based application is just a transformation of an on-paper nomogram to a web. So we can't fool the crowd here.
No. It is. For example, if you have all the variables, if you have a patient's age, all the data from the 5.
My question was different actually. It was like, suppose if I am doing a very complex partial nephrectomy, today seeing your nomogram, should I totally give up on that? That's the question.
No. So there is
it's basically to have a better idea of what
is
amount of complication you are going to have and to counsel the patient.
It is just basically for counseling. Renal nephrometry score, even the scores of 12, it doesn't signify that we should abandon the nephrectomy. It is
but
just
it does say in the MD calculator that there is a 14% chance of urine leak
that
and
is
there
what
is
is in
a
development.
10% chance of some complexity. It does say that.
So that we can counsel the patient accordingly then.
So that is what is in development, and we can actually tell patients that this
I think we'll go ahead then. Identifying patients for adjuvant therapy for after nephrectomy. Let us initially have a small surgeon discussion and then take Dr. Kumar's view as what he sees in such patients later on, when they are not given probably or too late given therapy. So what we know is all these things: source, assure, S-track, and then I just put these slides because these are the therapies. Nivo cabozantinib has a role. Probably Randeep just told me that it is an upfront, you can give it in any patients. Keynote 564, I think a lot of big time data and results were reported on that. So, sir, if you have these, okay.
No. I mean, I can comment on this.
Yeah, please.
For me, I don't think there is a role of any adjuvant therapy. There is evidence-wise, there is no evidence to prove that. And rationale-wise, there is no rationale in either giving ICI or sunitinib.
Okay, so
pembrolizumab does have a role to play.
I mean, it has evidence.
It has evidence, yeah.
So I have changed my practice to basically counsel the patients. So once I see that the patient has a tumor which is T3 or
I'll just give a scenario.
Yeah.
I operate a IVC thrombus which is intrahepatic with a lot of hilar nodes which all come positive, Fuhrman grade 3, clear cell RCC.
Yeah.
What will you do post-op?
Obviously,
Surgery is clean.
I would counsel the patient about the role of the potential role of pembro in this setting, and I will tell the patient that there is one study which is supporting this, and that also disease-free survival, not an overall survival. And I'll also tell that there are another 2 studies which doesn't support this. So we don't know, and they have to take informed decision based on cost is also a factor.
Okay. So coming to, I don't know, malab, this may be theoretical, but if
I-
cost is a factor with Pembro, we did have those S-track also. So would you go at a lower cost?
So Sunitinib, no.
Most of the time, no, a medical oncologist does not start because there is no clear-cut evidence, so they don't commence on treatment. But sometimes when
But why
we
do you
force
say
them-
no clear-cut evidence? Dr. Kumar is going to comment in the last.
Yeah, so they're reluctant to start. That is what I have seen. But I mean, we can sometimes when we force them, no, they start. That is what happens. So mostly I base on like my gut feeling. No, when there is like a PT3 disease with clear-cut perinephric desmoplastic reaction, IVC thrombus, renal vein thrombus, young patient who can tolerate all these therapies. I give a suggestion to a medical oncologist whether we can start. And some of the patients we have indeed started on sunitinib. Those side effects are quite bad, but still they tolerate. I mean, duration of therapy, no.
Any
no
long-term
consensus.
follow-up with such patients?
1 or 2 years, not more than that.
Okay.
And eventually they tend to.
I think let's take quick opinion of, I think, because we know what is the evidence, the referral practice for adjuvant therapy is slightly skewed, if I say so. Am I right? Because some people will send patients, some people will not do that kind of counseling. Anybody can say that from the audience, I don't mind.
So I'll comment regarding first part, the skewed referral. No, it is, see, anything new comes, it takes a time to accept it. You and me know new adjuvant chemotherapy in bladder took years, decades to have acceptance, what we have now. So that's a fair part. Second, rationale. Yes, there is a rationale. When you have a half of your patient dying in next 5 years, there is a rationale that you want some treatment to make it better, that either they survive more or they live more or they live more without disease. So definitely there is a rationale that one should explore treatment like this. TKI, I do agree, NCCN guidelines suggest there was a trial positive, 2-3 negative. Usually people are not so keen. Ganesh knows we are also not so keen in TMH when we were together. Coming to immunotherapy, 1 trial positive, 2, I think so 3 is negative. I totally agree. There are negative study. This trial, all updates has been positive. I don't know, it is a surprise for me. But this is similar issue in bladder cancer also, that there is 1 trial positive, 1 trial is negative. The positive trial this time got updated and presented in GU ASCO. And the difference in survival for PDL1, DFS is 12 months versus 50 months. Not easy to ignore those kind of data. So here also in kidney cancer, what I'll suggest that the discussion should happen. I'm not saying one has to give in every patient, but to say that discussion should not happen, meaning that we're thinking that that data which has come, and you don't have alternative unless you have it. For example, I say T3, all thing good, Fuhrman 1, perfectly fine. But what was suggested by Ganesh, in that trial, metastatic patient who had a artery resection was also included. Then you will say, we have 10 nodes, you have removed it, T3 tumors, not easy to ignore. So having a discussion definitely should be there.
So maybe have a good counseling, have discussion and offer. Quick comment because.
Last 2 years I'm using more of adjuvant with help of because in the abstract trial compared to Ashro trial and all, the selected patients were more, they selected the most high-risk patients. So it has got, so it showed some benefit. Like Pembro trial showed some 50% benefit in the disease-free survival.
Right.
So considering these two, what I do is in selected patients where there is a IVC thrombus or with infiltration of vein or lymph node positive, I routinely give adjuvant.
So maybe we should discuss selected patients, go on for it. This abstract was presented by Amandeep. Upfront cytoreductive nephrectomy for MRCC
Ganesh.
treated with.
Here,
Yes, sir.
a quick comment I can have.
Please, please.
So, I mean, what we have learned, giving adjuvant therapy in multiple cancers with success in most of the cancers, not so great success in RCC as of now. One thing I will definitely say that don't give adjuvant therapy in the lowest risk cancer. Don't expect a miracle in the highest risk patient. Identify who are the intermediate risk, who are likely to benefit. And that is the tough job that we together have to find out.
Okay, well taken.
I don't think so.
So probably we might not. God knows.
So debate should have been totally, and this is very important what he's making a comment. If I have aspirin or paracetamol, 1% benefit also becomes important. But the moment something costs 4 lakh, then we look for what is percentages of benefit what the patient has. And absolutely fine. I'll give you an example. And published from Tata Hospital, we had a lignocaine trial by Dr. Badwesar, 3% absolute benefit. But lignocaine cost a few hundred rupees. This is and this has got covered into so many places, including JCO with editorial. So you do have a cost also giving you where you want to use what. Totally agree with you.
Just a comment to Amandeep. Amandeep, this is not aspirin. In adjuvant IO, we will be discussing that in the next session, has toxicity. And there is a discontinuation rate of 20%. Discontinuation. So even if it is 1 rupees, then also the patients are, and then Kumar sir will agree, it disturbs the whole algorithm of metastatic settings when they relapse. If someone has received 1 year of pembrolizumab and they relapse after a year, we are confused about our algorithms will definitely, or we will learn with time.
This is a very fair comment by Randeep, and that when you don't have, there is something to be worried about, and I do agree with the comment, from this side. This has happened multiple places. I told bladder cancer, I told kidney cancer, you have a negative study. Here we have 3. Head and neck cancer, we have a 3 negative study. Drug works so well. 10 seconds. Head and neck cancer, in metastatic setting, it works so well. You have a 30% 5-year survival, 4-year survival. We have never heard in metastatic setting in head and neck cancer. Adjuvant 3 trial, randomized trial being negative. So what Randeep is saying, Kumar, if you're giving an adjuvant setting which is useless, in meta setting, are you disturbing the algorithm? You have a fair point, Randeep. So be careful.
Yeah. So the paper about upfront cytoreductive nephrectomy in MRCC, this is all was presented and we know this. This is what we are doing, but there are enough places where as per this retrospective multi-center big study, very big study I should say, 4,000 plus they are doing. I mean upfront cytoreductive nephrectomy in young, good performance status, fit patients, nicely looking patients. Whether, sir, it should be done like that, or should we follow the proper protocol and then we should see the IMDC scoring and then go ahead?
I see no reason in the circumstances that you've just mentioned, people without brain-bone metastasis, people who are young, good, favorable IMDC scores, I don't see any reason why we should
but when you say young, no brain bone, stroke, when you then separate good IMDC score, then one is objective, one is very subjective.
No.
I mean the criteria are subjective. So I will operate the best of the prostate cancer patients and send the remaining to my radiation friend. So
but that's their job, isn't it?
We used to have a discussion long back, 10 years back in Tata Hospital like that. So it is that kind of logic. If I give him equal patients, he'll produce results which is quite good.
You can't. In the unfavorable patients, it is already proved that it doesn't work.
Okay.
So the surgeons are a privileged class, isn't it?
So there was a good deal of matching which was tried in this very large study. I agree with that, IPTW matching. Puneet, I don't know if you have gone into details of this paper.
I have gone into details,
there was a lot of matching, it
like
was quite confusing.
I could understand a bit of statistical analysis, but not the whole lot of it. There was something called multivariate confounding.
I also thought so. I mean, there was a lot of matching tried, but God knows.
What the gist was that they tried to evaluate, had both the groups been of the similar settings with similar criteria. So what would have been the results in that? So even after that, they found that the upfront cytoreactive nephrectomy was better in both targeted and PKI, targeted and ICI.
Reverse engineering. The target was decided, and we looked into that.
So what I think is that had it been like based on the IMDC criteria, you divide have a good risk patients, intermediate, and then poor risk patients, and then evaluate subgroup, do a subgroup analysis. That would have been probably a better thing.
Maybe. Sir, the question is for you, Dr. Mandani, sir. The fourth question. I think we'll end this abstract after that. So, will you change any practice which you do today, or you will continue with the same?
Absolutely not. I would try to remove as many sites as functionally possible and just observe.
Okay.
And if he has residual disease, then only I'll consider him for adjuvant. Otherwise, no disease.
Not adjuvant. This is an upfront cytoreactive.
Upfront, apart from nephrectomy, as many sites as functional.
So the guideline says that if upfront cytoreactive nephrectomy you should do if you are able to remove that as well as all the metastatic sites.
So that is in a oligometastatic in a group somewhere which are there. So coming to the two radiation topics which we had, bone only oligometastatic renal cell carcinoma. So bone involvement is seen in 20 to 35%, and this was said in the presentation by Dr. Sayan. OS is higher with a solitary, and then as the bone mets increase, it goes down. So what do we routinely do? You have a large renal mass, Dr. Kishore. So the first question, will you always properly do a bone scan?
We do a PET scan, okay, and we have encountered at least 3-4 cases where isolated mets in the clavicle.
Okay.
Long
so all renal cancers, you will do a PET scan?
Most of them.
Why I put this question is because sometimes, I've seen many patients where a small renal mass or a 7 centimeter renal mass, nobody does a metastatic workup. They operate.
I mean, some cases you do, it mandates, yeah.
If I say so, PET CT everybody is getting, but that is not the standard protocol.
Not standard.
And many times you do a CT abdomen pelvis where you have lower cuts of the lung also. We are talking about bone, but even upper lung is missed in that. So I'm saying bone is not even touched in the preliminary investigation.
But it can happen, solitary mets.
Yeah, I fully agree with that.
Yeah. So we have gone ahead and resected it actually with the help of orthopedician. The solitary mets. We haven't had any experience giving a stereotactic RT to the bone. So.
Okay. So technically, if you see a patient, sir.
Initial workup, calcium and alkaline phosphate.
If alkaline phosphate is raised, we would always do a bone investigation. Right, sir.
Still there. But now change to
PET scan. So if there is a, say, solitary or a bone oligo thing, solitary, how you manage it?
No,
because one thing I always feel is it is an multidisciplinary team discussion. Rest you answer, please.
Yes, SBRT is very straightforward, especially bone mets, spine mets, easily treatable. This abstract has shown 90% control rate, which I think is fair. It's as good as any surgical resection. So it's SBRT is now ubiquitously used across the country.
So one small question, suppose if there is a solitary in the humerus and you are sitting in a multidisciplinary with Puneet, so would there be a debate between doing a surgery and excising or doing a SBRT?
So normally bone metastasis, after surgery, we invariably follow it up with at least a 30 grade 10 fractions palliative RT.
Like surgery for the bone only?
What would be the surgery? I mean, for
just excision and stabilizing of the bone. Yes.
If it's an R0 resection, then okay, otherwise SBRT easily treatable, easily possible.
Anything?
Interesting if you see, when an axial skeleton is affected, probably the results are poor, especially with the fixation. Or on the other hand, if the long bones are affected, the resection is quite efficient. That is what I have seen that.
So there is a paper regarding this. If there is only a single bone mat, and if you are doing a resection versus no resection, and even only giving adjuvant therapies, resection is seen to be having a better survival. And that resection need not be a wide resection. Okay. If you are doing a wide resection versus your intralesional or stabilization, Both the things were evaluated, and these patients did better as compared to
Dr. Sayan, any take you have?
They had written adjuvant therapy. There was multiple radiation also was given, and then adjuvant systemic therapy was also given.
So maybe radiation was not SBRT.
Yeah,
It's a old paper. I think it's a 10-15 years old paper.
But in the article that I presented, that spine metastasis did better than other
Exactly.
bone
Kishore
metastasis.
said
Yeah, so if it is in humerus, suppose not spinal metastasis, maybe metastectomy is also a good option
3 minutes.
in that case, because it is not in the spine. And doing SBRT in a humerus, it can be done, but I feel like it's not that easy.
So you will be more comfortable with
the spine or
okay. So coming
That
to
must
the
be
last
That
paper.
must be the biology of the disease. They said the better outcome was with the spine metastasis, not with the spine SBRT as such. So it's probably representative of the...
No problem, but the article says that it's spinal metastasis, they did better with SBRT.
Yes, it's the
So metastasis
biology of the disease, not so much the
So
SBRT
spinal,
technique.
yeah, that is the biology of the disease, but that does not mean that SBRT cannot be done in the humerus. It would be much more simpler. We don't have a critical organ.
Agreed. I think that is the point.
And also it would be a non-invasive thing also. So.
Yeah, right. But what happens is sometimes we consider that solitary metastasis in an RCC would probably be a slightly better biology. This is one thought which is across in our literature. So I think we'll require 2 more minutes. Okay.
Radiation oncologist, what is the plausible reason for radiation being effective in such setting? The last two papers.
So whenever we do SBRT, we are giving a very high dose per fraction, and RCC we've seen giving high doses per fraction works much more effectively. Yes, the dose per fraction, yes. So it's the radiobiology is different. So even if you see numerically, it may be 40, 50. It is not equivalent to the 50 that we give in the pelvis. The EQD2 or the biologically effective dose is much higher.
It is 5 times the daily dose given in 5 days. So the cell kill is a different mechanism. It's completely ablation.
Yes.
It's as good as ablation. We call it ablative radiotherapy in most places.
That's the point. SBRT is ablative dose. It's completely different radiobiology. It's not like the conventional fractionation radiobiology.
So today you have an RCC with say 2 spinal metastasis. Dr. Aditi, what would you do in a MDT? Suppose if I operate the patient and refer to you for the spine meds, will you do a SBRT?
Sir, RCC operated.
You will discuss with the orthopedic surgeon to do something.
Sir, if I feel the spine is unstable, there is a soft tissue mass which is compressing the spine, the patient is having sensory motor deficits, I would definitely take an opinion to decompress, but otherwise I would go ahead and do SBRT.
There's a SIN score,
Yes.
spine instability score.
Yes.
So if the score is beyond 7 or 8 out of 15, then we need to operate.
Okay. Since we are at this point in discussion, I'll add just one small comment I need from Dr. Kumar. We operated the patient. She has given radiation to 2 spots, SBRT. So we have killed the disease. Patient comes to you for the third opinion. Would you add any ICI or anything?
So idea is that. So I think
these situations are real life. Patients do ask for this, and that is why this is the best forum to discuss.
I totally agree. So, do we have evidence for it? So, if you take lung meds, we have a good evidence that you remove it and George removes it. So that evidence I have. So George means he was my thoracic surgeon. Now he is with him rather than we both were with together. All of us were together. And we have patients. I have, in fact, almost a dozen patients like this, where something has been removed, you remove it, and then you keep in follow-up. We have. Do we have a bone? No, that is the challenge. Challenge is that your SBRT, we do practice it. Vedang is there, and I just saw my colleague, she was there. So we do use SBRT, and that's why I wanted to make a comment. No, we have seen effect. If you give SBRT, we have seen symptoms going down. So I do agree with you. SBRT does work with that dose in kidney cancer. Does SBRT removes the tumor in kidney cancer? No, that's something one has to ponder over. That at this moment, we are waiting for it. It is possible that tomorrow we have evidence that 5 years, 7 years down the line, that we don't have an issue. Issue is that if disease comes back and it comes in brain mets and you have not given systemic therapy, that's a challenge. That's the reason in this situation, I'll prefer that we do give
So one more thing, the inclusion criteria, if I'm wrong, I don't know, but Keynote 564 was also such type of patients, right?
Yes, that is true.
Keynote 564 had these patients also.
That is true.
In that, correct? They were less, but they had included them purposely in this kind of
Hazard
thing.
was on the same side. In fact, hazard was better. Yeah, correct. A very good hazard for these patients.
Okay. So this is on the last abstract, outcomes of RT plus immunotherapy, which Vinay presented, and then we had these patients not doing well in the paper. Am I right?
Yeah, absolutely.
So this question to you, is there potential ability for RT to induce abscopal effect or not?
It was a mythical belief. It still is mythical belief. This is proof that this is absolutely a mythical belief. Those patients who received radiation have not benefited.
So you don't believe in astrology?
I don't believe in abscopal effect of radiation.
So sir, Amit Ghosh sir, if you see patient of MRCC and these options are there, we had outcome of radiation therapy plus immunotherapy. So RT to the kidney, right Vinay?
No, bone size, in any radiation.
Metastatic site.
Any radiation.
Invariably it was bone mets or brain mets.
Brain mets.
And
Not to the primary.
not to the primary, not to primary.
So would you prefer any kind of surgery, RT?
Not RT.
No, where to, sir? The question is where.
No, that's okay. That's okay.
No, that- obviously for the kidney,
No,
there won't be
even-
an option of radiation, but if it's brain mets and if it's not operable by a neurosurgeon, then definitely go for
We
radiation.
have a solitary lymph node mets, no? Which is quite a common occurrence after local advance. Can we do?
Yes.
Yeah, SBR is very easily possible for such a site to at least 40 grain, 5 fractions. It's a-
Depending on the location, we need to see what critical structures are, and accordingly we can.
But solitary lymph node, won't you remove it? Like, so lymph node, bone was concerned.
Sir, if the patient is not fit for surgery or something like that, then definitely.
All
So,
lateropharyngeal, all those are not
so he
close.
asked whether we can do it technically. Yes, we can do it
Totally agree.
technically.
But with a lot of limitation, isn't it?
No, not necessarily. It depends on which structure is
Sir,
nearby.
depends on the location. Depends on the location, what all critical structures are, because...
Around.
Yeah.
So the good thing about SBRT, no, sir, the vessel is not a critical structure for us.
Yes.
Sir, vessel is not a critical structure. If it's close to the aorta, close to the the IVC, it's not a problem at all. You can go up to a full dose of 50 gray. What is important for us is the bowel. If the bowel is very close by or if the spinal cord is very close by, these are the structures which we are scared of. We can't push the dose beyond a certain limit. But vessels are good for us. So what you can't remove, we can easily irradiate.
So the last,
And we have already preliminary phase data of 14 patients who have done reasonably well, but also it is short term. So maybe 3 years later, in the year in review, we'll be talking about...
so this is with SBRT. Ginil, you want to say something?
Actually, the cyber knife in two scenarios. One is the hereditary malignancies, small malignancies, whether we can use to avoid a surgery in VHL. And also in primary malignancy, instead of active surveillance, we can have a cyber knife and follow-up.
Okay.
These two is more and more explored, and there are some preliminary data.
Cyber knife is only a technique, it's a machine which practices SBRT. It's essentially SBRT.
Right.
So primary SBRT to the RCC, I actually also have a little bit of experience. One of the old patients which was referred to me, not fit for surgery, relative of actually a radiation oncologist. Then we discussed about that SBRT. The problem is, how do you follow that patient up?
How do you follow up the patient in whom you will give SBRT
imaging wise,
to
what you
the-
are going to see?
to the kidney is saying. How will you follow up that
If
patient?
the disease is PET avid, the avidity will go after about 12 weeks.
It's a question, because sometimes you're not able to make out that whether it's a recurrence or it is not there.
So we need a baseline evaluation, and whatever is seen abnormal on a baseline evaluation, that abnormality is lost. If there was contrast enhancement in the baseline evaluation, that is lost.
See, contrast enhancement, diffusion restriction, PET avidity, these are the only things. We don't go and biopsy and prove it whether it is positive or not.
So I wanted to ask you this last question, Dr. Kumar, I think you only answer that. Why the RT plus IO arm did quite bad here? Why?
Yeah. See, one of the issue with this kind of analysis remains now. Which kind of most likely this patient would have been symptomatic, would have had more disease. So we forget that when we intervene usually with a therapy when you have more disease, more symptoms. So most likely, is it harmful? No, there is a randomized trial for this scopal effect, I think so in head and neck, and that was a negative study. But being fair, again, we don't have the last answer. And second, negative I have not seen. This was a bit of a surprise.
Exactly. I mean, at least it should have been same.
Hello.
Right, no?
More than 3/4 of those patients received palliative dose.
Palliative, what is it?
So purely palliation and not with the intent of local control.
And with
So
8
when
grade single
your
fraction, we
intention
don't
is not-
expect any response.
Question is not for Ganesh. Ganesh is asking question. Whatever you gave, I agree. Your argument can be, it was not SBRT, so you don't have scopal effect. Some effect. Negative, you don't expect to see negative.
IO was given on both sides. So it should be same probably. That's what I said.
No.
Because when you're doing fractionated, then if they are poor performance status, disease burden is higher. When you're doing high fractionated radiotherapy, SBRT, disease burden is lower. So probably they could have done better. I mean, it's just an afterthought.
So this is in Canada. It is state-funded health. So they need to justify every treatment. So those patients who are really symptomatic or really needed treatment only would have got the treatment. So they are the bad biology disease. It's purely selection bias.
So maybe. Thank you. Thank you so much.
Thanks a lot, sir. Thanks to the panel for a wonderful discussion. I think we're going to take 2 sponsored sessions now, since we are ahead of time. So Bakshi sir, if you can still stay up to deliver your talk on agonists versus antagonists. And after that, Dr. Kumar Prabhat sir for case studies in metastatic disease.
Thank you. So this is a sponsored session from about AstraZeneca, Unleashing the Controversy, LHRH agonists and LHRH antagonists. Prostate cancer has the 2nd highest incidence and is the 5th leading cause of cancer-related deaths among the males. These are general statistics. Also, if you see the Indian statistics, we have some different cancers which are up. Prostate cancer comes a little down. And these are established steps, important steps in the journey of any prostate cancer patient. So it does start with very, very early prostate cancer. An important milestone is a high-risk localized, then locally advanced, then metastatic, hormone sensitive, and castrate resistant. So these are aspects where LHRH agonists, LHRH antagonists do work, and both prevent or cut off the testosterone with different mechanisms. So LHRH has a reverse inhibition, as you all know, and LHRH antagonists bind directly and stop producing the LH, which does not further produce testosterone. So if you see the actions, antagonist acts in up to 96 hours, agonist in 3 to 4 weeks. There is a flare which does not happen with the antagonist and which may be seen in the agonist. PSA failure of 8.9% versus 14.1%. Injection site reactions up to 40% and very less with the agonist. Cardiovascular complications mentioned similar. Antagonist has to be given monthly. Right now it's an injection. Agonist every 3 months. So all LHRH agonists are deemed kind of equal. Antagonists equal to antagonists, important in patients who need rapid reduction of testosterone. So by many guidelines, they are used in patients with spinal cord compression, impending paraplegia, severe bone pain, or bladder outlet obstructions. These are the pharmacokinetic profile of goserelin and degarelix formulations. As you see, monthly goserelin is available and degarelix, as we know, is monthly. So no dose adjustment for mild to moderate hepatic impairment is required with goserelin, unlike the degarelix. Goserelin has a clinical data across 3 key prostate cancer settings: in the localized prostate cancer, locally advanced, and the metastatic. So in the localized, a 40% improvement in the 10-year survival has been seen versus RT alone in combination with radiation. So the EORTC 22863, it's an old study, goserelin adjuvant therapy in high-risk localized or locally advanced prostate cancer, phase 3 randomized trial with a primary endpoint of clinical DFS, and a secondary endpoints of OS, distant MFS, cause-specific mortality and loco-regional control. In this, there was a long-term follow-up of 9.1 years. The randomization was 1:1 in radiotherapy plus goserelin versus radiotherapy alone. Here, the goserelin was given for 3 years. And if you see the DFS rates, 10-year DFS, 47.7% with the combination versus 22.7%, and prostate cancer-related mortality 10.3% in the combination versus 30.4% in the only radiotherapy arm. There was a 40% reduction in the risk of death with adjuvant goserelin. As seen in this graph, the curves do separate well. And the 10-year OS, 58.1 versus 39.8%. In the DART 0105 VACOR study, high-dose radiation with short or long-term goserelin was used in localized prostate cancer. And here, localized prostate cancer also included up to T3B patients, which are T3B are high risk, and randomized into short-term androgen deprivation of 4 months versus only neoadjuvant versus neoadjuvant and adjuvant. So here the follow-up duration was 63 months, and after a median duration of follow-up, 64 months for the long-term deprivation group. Biochemical DFS, as seen, again the curves separate, 90% 5-year DFS versus 81%. In the long term, it was always better with a HR of 1.88. 5-year overall survival benefit with long-term versus short-term goserelin. So 5-year was 95 versus 86, again better. And going further, in the locally advanced prostate cancer stage, 46% reduction in the risk of progression over 10 years when added to radiation versus radiation alone. This is in the locally advanced prostate cancer stage. And there are RTOG 8610, TROG 9601, and GETAC FU 616, all these 3 trials. So RTOG 8610, goserelin was used as neoadjuvant in locally advanced prostate cancer. T2 to T4, M0 with or without pelvic lymph node involvement with the locally advanced group in the inclusion criteria, and randomized to neoadjuvant goserelin plus followed by radiation and goserelin versus radiotherapy alone. Now, it's a standard of care nowadays to offer multimodality in these kind of patients. Here the median follow-up was 6.7 years. This trial was published long back in 2008. And a 10-year survival update was performed at a median follow-up of 10.6 years. The primary analysis conducted at, as I said, median follow-up of 5.9 years. At 10 years, 23.3% versus 35.6% had died of prostate cancer in the goserelin plus flutamide plus RT versus the RT alone arm, and 51% reduction in the risk of prostate cancer specific mortality over 10 years with the addition of goserelin. Survival results with neoadjuvant goserelin plus flutamide and RT versus RT alone. So at more than 10 years of follow-up, overall survival, OS rates were 42.6 versus 33.8, and all-cause mortality was significantly improved in the patients receiving 6 months of neoadjuvant goserelin plus flutamide and RT versus RT alone. So 10-year all-cause mortality, 3-month arm, 0, 3 and 6-month arm were 42, 36 and 29.2%. GETAC AFU 16 adjuvant goserelin following radical prostatectomy for prostate cancer. So in these post-RP rising PSA 6 months or later, patients were randomized for 6 months of goserelin plus radiotherapy versus radiotherapy alone. And primary endpoint was PFS with a lot of secondary endpoints, OS, MFS, acute and late toxicities, changes in QOL. Primary analysis was conducted at 63 months. And as you see, the PFS rates, there is a 46% reduction in risk of progression over 10 years when goserelin is added to RT. 64% versus 49% in the 10-year PFS. So if you see the forest plot, it favors radiotherapy plus glycosylline. So patients, as per this study, patients who were post-RP needing radiation therapy, there would be more benefit with adding glycosylline. Glycosylline has, again, this going on to the metastatic prostate cancer. It has been as effective as surgical castration in the clinical outcomes. So the initial papers were surgical castration rates of testosterone. The glycosylline paper had reduced testosterone levels of less than 20. And in these publications with Kayseri et al., phase 3 randomized multicenter trial, the primary analysis was conducted at median follow-up of 63 weeks. The patients had all histologically proven metastatic prostate cancer, median follow-up of 2 years, and there was clear benefit, again a similar trial by Vogel-Zhang. So the glycosylline here everywhere was as effective as a surgical castration, which was considered the standard of care. So if you see mean time to response, it is as good. The mean duration of response is as good. Comparative data between surgical castration and medical castration, almost same with glycosylline. Large clinical trials with extensive follow-up, again, with all the 3 stages of localized prostate cancer, locally advanced and metastatic, shows good effect and benefit with using LHRH agonist glycosylline. Recommendation for ADT across disease states is quite consistent between the guidelines today. NCCN, EAU, ESMO, ASCO, all use LHRH in high-risk localized disease with radiation as neoadjuvant as well as adjuvant. In locally advanced also, ADT of 2-3 years has been used. There are papers which have reduced this duration in some high-risk localized to 18 months from the earlier 36 and 24 months. And M0 or M1 CRPC, castrate levels of testosterone are yet maintained by continuing the medical castration, or the sometimes these patients are pushed on to the surgical castration. So if you see the overview of LHRH agonists and antagonists, there are a couple of agonists, glycosylline, leuprolidine, triptorelin, buserelin, and degarelix still stands across all of them. Has been used, if you see the overall use, it has been, all these drugs have been used in most places. This is the administration of glycosylline 3.6 and 10.8 milligram implant in a pre-filled syringe for subcutaneous injection with a 16-gauge needle or a 14-gauge needle, and a single-step delivery system which is comfortable. Implant helps in a gradual release of medicine over the intended period, and it's safe. Moreover, it is not a liquid injection, so they don't have to prepare anything, no displacement of the bubbles. Degarelix as an injection is a monthly depot formulation given subcutaneously, starting with the initial dose of 240 milligrams, continued with a monthly of maintenance of 80 milligram, and frequent monthly administration is needed. Longer time required for injection reconstitution, inconvenience of 2 injections in the initiation dose, efficacy evaluation, glycosylline versus degarelix. So head-to-head comparisons have happened, and there are data available in 2019, 2018 and 2013 with the primary outcomes, as you see, testosterone suppression, and secondary outcomes which are testosterone suppression, PSA failures and PFS. So going on with these studies, the interpretations do say all the direct comparison trials were open label, included patients of different stages of prostate cancer, and were primarily designed to prove that degarelix is non-inferior. Overall treated population showed a comparable reduction in PSA level in testosterone, suppression to castrate levels, as well as in prostate volume reduction. Patients on degarelix showed a more rapid decline in testosterone and PSA levels compared to glycosylline. However, higher number of glycosylline treated individuals achieved reduction in testosterone. This is with Ozono et al. Degarelix could not prove non-inferiority to goserelin for co-primary endpoint days 28 to 364. Most of these RCTs compared the 1 monthly formulation of both drugs. The studies had inherent limitations in study conduct, design conduct and statistical analysis, and hence warrant further research. Going on to this article, a change from gonadotropin releasing hormone antagonist to gonadotropin releasing hormone agonist therapy, which this kind of practice is used by quite a few of clinicians who, when the need of a rapid testosterone suppression is needed, use Degarelix and maybe later on switch over to the agonist. So as you see the graphs, the overall 5-year survival was statistically superior in the changed group than that in the continued group. The 5-year cancer-specific survival was also superior in the changed group. Shifting patient from Degarelix to goserelin was associated with improved 5-year survival. This is what was published in this Japanese paper. The efficacy and safety of Degarelix versus Lupride. So the study design, and there was a faster testosterone response which LH antagonist, which kind of equalizes after 14 days. Faster PSA response with LHRH antagonist, this is what we said, and no difference with the anti-flare treatment. The subcutaneous Degarelix injection was associated with a slightly higher rate of 40%. That's a higher rate of injection site reactions than almost very, very low injection site pain or any other reaction with LHRH agonist and goserelin. Safety concerns, injection site reactions, clots reported significantly higher ISRs in the pooled Degarelix groups, 40% versus the LHRHA groups less than 1%. These reactions were mostly mild or moderate in severity and occurred predominantly after the first injection, 33% versus maintenance dose injections where this reaction was lesser. The author suggested that the difference in ISR might be due to the different forms of administration. Anti-Degarelix antibodies have been observed in 10% of patients after treatment for a year and 29% of patients after 5.5 years. A head-to-head comparison of goserelin and Degarelix reported that only Degarelix treatment group had any ISR, that is pain, erythema or swelling. Higher incidences of ISR in this study was attributed to higher maintenance dose and injection volume and more number of injection sites required. Only one site required for 1 month regimen versus 2 sites. So this was a study with Japanese study. And in the interpretation of injection site reactions in an SRMA, the incidences of ISR was significantly higher in patients receiving Degarelix compared with those receiving goserelin. Similar results for ISR were also reported by other SRMAs, Fang et al., Hosseini et al. Thus, individual studies, head-to-head comparative studies and meta-analysis demonstrate a significantly higher incidence of ISR with Degarelix than with goserelin. As coming to cardiac safety, the PRONOUNCE randomized trial, which was of say cardiovascular safety of Degarelix versus Luprolide, the results due to slower than projected enrollment and fewer than projected primary outcomes, enrollment was stopped before 900 planned participants were accrued. From 2016 to April 2020, 545 patients, 113 sites across 12 countries were randomized. And further baseline characteristics were balanced between both the groups. And in the clinical perspective, the relative CVS safety of antagonists compared with GnRH agonist in men with prostate cancer and known atherosclerotic cardiovascular disease remains controversial. PRONOUNCE is the first international randomized clinical trial to prospectively compare these. The study was terminated prematurely with smaller number of events with smaller than the planned number of participants and events, and no difference in major adverse cardiovascular events observed at 1 year between both the drugs. The relative cardiovascular safety of GnRH antagonists and agonists remains unresolved. CVS events might be lower in patients with prostate cancer through better awareness and attention to cardiovascular risk factor control in the light of improved cancer survivorship and the competing risk of CVS disease. There is an ongoing need for a rigorous cardio-oncology clinical trials. PRONOUNCE provides a model for interdisciplinary collaboration between urologists, oncologists, cardiologists. efficacy and safety of degarelix, results from a phase 3 study from China. So here, the most common SAEs were cardiac disorders, which occurred in 5 patients. The incidence of treatment emergent AEs were higher with degarelix than with goserelin in this particular study. Safety findings, the incidence of treatment emergent AEs was higher with degarelix, as I just said. The most common SAEs were cardiac disorders in 5 patients in the degarelix groups and 2 patients in the goserelin group. 2 patients receiving degarelix had increased PSA levels. Coming to this other publication from 2006, diabetes and cardiovascular disease during ADT. Observational study, GnRH agonist treatment for men with locoregional prostate cancer may be associated with an increased risk of incident diabetes and cardiovascular disease. Benefits of GnRH agonist should be weighed against the potential risks. So diabetes is another major risk factor when you are giving ADTs. And clinical interpretation, degarelix achieves rapid achievement of castrate testosterone levels that enable it to be used in aggressive prostate cancer for progression. However, a wider use of degarelix is restricted by the lack of dose that lasts more than a month and a higher frequency and severity of ISR. There are reports of degarelix used to ensure rapid testosterone suppression without a flare, followed by a switch to a more tolerable and easy to administer LHRH agonists. The NICE guidelines also report that despite advantage of degarelix providing more rapid and improved disease control and no testosterone flare, antagonists should not be used as first-line ADT. Goserelin has been used effectively since more than 3 decades. To conclude, LHRH agonists form the most widely used form of ADT. Goserelin is a widely used LHRH agonist with a large evidence base with established short-term and long-term clinical efficacy and survival benefits in broad spectrum of prostate cancer population. It has a unique and safe implant delivery system. Degarelix has challenges like ISR and inconvenient monthly formulation. The evidence with regards to CV safety have so far shown comparable results between both agonist and degarelix. This is the formulation. Zoladex LA, goserelin acetate implant of 10.8 milligram 3 monthly. Thank you.